With hypernatremia, hyper means high, and natremium is Latin for sodium, often shortened just to Na+. And emia refers to the blood, so hypernatremia means a higher than normal concentration of sodium in the blood, generally above 145 milliequivalents per liter. The concentration of sodium depends on both sodium and water levels in the body. About 60% of our body weight comes from just water, and it basically sits in two places, or fluid compartments. A third of it is in the extracellular fluid, meaning outside the cells, and 2/3 of it is in the intracellular fluid, or inside cells. The extracellular fluid includes the fluid in blood vessels, lymphatic vessels, and the interstitial space, which is the space between cells that's filled with proteins and carbohydrates. Normally, the two compartments have the same osmolarity, which is the total solute concentration, and that lets water move freely between the two spaces. But the exact composition of the solutes differs quite a bit. The most common cation in the extracellular compartment is sodium, whereas in the intracellular compartment it's potassium and magnesium. The most common anion in the extracellular compartment is chloride, whereas in the intracellular compartment it's phosphate and negatively charged proteins. Of all of these, sodium is the ion that moves back and forth across cell membranes. And subtle changes in sodium concentration tilts the osmolarity balance in one direction or another, and that moves water as well. And this is why we say water follows sodium. So with hypernatremia, someone can have a high concentration of sodium in the extracellular fluid, and therefore the blood, by either losing more water than sodium, or gaining more sodium than water. Either way, this increases the sodium concentration in the extracellular fluid, which draws water out of the cells. When hypernatremia develops over a long period of time, the cells get time to adapt and they start generating osmotically active particles, which end up preventing water from being lost via osmosis. When hypernatremia develops acutely, though, the cells get no time to adapt, and the loss of water leaves them shriveled up and can cause them to die. Now, there are several common causes of hypernatremia via water loss. All of us lose some free water every day without even realizing it, for example through the sweat as well as through the moisture breathed out during normal breathing. Under normal conditions, though, this loss is replaced by the water we drink, but this balance can be tipped when you have a high fever or exercise a lot on a hot summer day. In those situations, you can have temporary hypernatremia, which is easily fixed by drinking lots of water. Another way that the body can lose free water is through the kidneys. When the nephrons of the kidneys filter blood and form urine, some of the water in the filtrate is reabsorbed in the distal convoluted tubule and the collecting duct. When you're dehydrated, the hypothalamus releases antidiuretic hormone, also called ADH or vasopressin, which acts on the receptors on the nephron to boost its ability to reabsorb water. So if there's brain damage affecting the part of the hypothalamus that controls the release of ADH, then ADH levels could fall and the nephron wouldn't absorb as much water, meaning more fluid gets lost and the urine becomes more dilute, and the sodium concentration in the blood gets more concentrated. This is called central diabetes insipidus, because the fault lies centrally in the hypothalamus. Another possibility is that the hypothalamus makes ADH normally, but the receptors in the kidneys stop responding to it. This time the fault is in the kidneys, so it's known as nephrogenic diabetes insipidus. Again, in this case, the urine becomes dilute and the sodium in the blood becomes more concentrated. Alternatively, there might be brain damage that only affects the thirst center in the hypothalamus, rather than the ADH secreting part of the hypothalamus. Here the kidneys aren't losing water, but the person drinks too little water while still losing some through the sweat, again resulting in hypernatremia. In rare cases, when there's major damage to the hypothalamus, ADH may not get released and the thirst center might be destroyed, which means that the person will lose a lot of water in the urine and still won't feel thirsty, which is a dangerous combination. Instead of water loss, hypernatremia can also be caused by sodium gain. This happens most commonly when a patient in the hospital is given sodium intravenously to help increase their sodium level, and too much is given too quickly. Occasionally, this can also happen simply because somebody's diet has too much salt. In either situation, though, the kidneys usually do a good enough job of getting rid of too much sodium, so hypernatremia in this case only usually happens if there's also some sort of kidney dysfunction alongside them. Symptoms of hypernatremia are related to the underlying cause. For example, some patients might have signs of dehydration, whereas others might have signs of excess fluid in their tissues. Individuals with central or nephrogenic diabetes insipidus also have polydipsia, which means they drink a lot of water to make up for the losses. Long-standing hypernatremia typically causes fewer symptoms, because the cells have a chance to adjust, whereas acute hypernatremia can cause cell death, particularly in the central nervous system, which results in serious problems like an altered mental status, seizures, or even a coma. The first step to diagnosing hypernatremia is to figure out if a person's intravascular volume is low, or hypovolemic, or normal, or euvolemic. If a person is hypovolemic, they're usually drinking too little water or sweating a lot, like on a hot day. In this situation, the kidneys are trying to hold on to water by peeing out thick, concentrated urine with osmolality of over 600 milliosmoles per kilogram. At the same time, the kidneys are also trying to preserve sodium, so they have a urine sodium concentration of less than 20 milliequivalents per liter. If instead in a hypovolemic patient the kidneys aren't functioning right and are losing sodium, then the urine sodium concentration will be higher than 20 milliequivalents per liter. And this could be as a result of medications like osmotic and loop diuretics, or even as a result of a kidney disease. On the other hand, if a person is euvolemic, then it's usually because their kidneys are dumping water, like in diabetes insipidus. In this case, their urine osmolality is usually below 300 milliosmoles per kilogram, and they have a urine sodium concentration of less than 20 milliequivalents per liter. Treatment of hypernatremia depends on the underlying cause, but ultimately the goal is to reduce the sodium concentration. For central diabetes insipidus, desmopressin is usually given to make up for the lack of ADH in the blood. For nephrogenic diabetes insipidus, drugs like thiazide diuretics can be given to increase urine excretion of sodium. If intravenous fluids have to be given, it has to be done carefully to avoid complications like cerebral edema. Alright, as a quick recap, hypernatremia is an electrolyte disorder that describes a high concentration of sodium in the blood, which can be caused either by losing too much water or by gaining too much sodium. Either way, hypernatremia can cause water to shift out of the cells, and in severe cases it can cause brain cells to shrink and die. Diagnosing hypernatremia involves checking the volume status and measuring the urine osmolality, as well as the urine sodium concentration. Treatment generally involves slowly and carefully giving back free water to normalize the sodium concentration over time.